Greetings, everybody. Sorry, as always, we're trying to figure out all the technology. Trying something new tonight for technology, so I hope that this works out perfect for you and you can see and hear me all right. So I'm going to say welcome, and I'm going to get us started because I'm going to be trying to do the a lot of information in a short period of time. So I don't want this. I don't want to take too much time in a lot of stuff. And I'm going to hold on for a second. It looks like we're still waiting for the technology to catch up here. So if you are hearing me, we're going to wait just one more minute before we get started. All right, everybody. It looks like our technology is working. Again, my apologies for being a couple minutes late, but anytime we're working with new technology, we're trying to figure it out. So hello to everybody, and welcome to our session on ARDS and the COVID virus. I just want to thank everybody for all the support you've given us this week and all the things that we've been doing. Your kind words are well appreciated, and hopefully you'll find this session as helpful as some of the other stuff that we've been doing. I want to start today with just giving you a very, very quick disclaimer. Sorry about that. My apologies. I'm still working with technology, so give me 1 second. I'm going to stop sharing for a minute. You'll be right back. All right. You should be seeing my screen here again in a minute. There we go. All right. Now, my only problem, and I'm talking to actually my tech people, is I can't advance my slides. So I'm going to keep talking while we... Okay, there we go. My apologies. I'm still trying to figure all this technology out. All right, so a quick disclaimer I'm going to give you is that I'm doing something that I've never done before. In almost 20 years of being an educator, my goal has always been to use references of 5 years or less. Guess what? Today, I'm breaking a record. Every reference you see on the screen, which I use to build this presentation, is 7 days or newer. I have never done a presentation where every one of my resources is 7 days or newer. But as the name novel coronavirus implies, this is new and there's no information available out there. So I'm working with just razor thin information today. So on the screen, you can see the resources I used to build this presentation today. As I said, all of these are 7 days or newer. This is brand new stuff. But what I'm finding, I'm going to guess you find the same thing at work, is that this stuff changes by the hour. Sometimes the things you're told at the beginning of the shift are no longer true at the end of the shift. So I would really encourage you to be really cautious in using my material or anything, as time passes, because new information may come out. And while I'm giving you the most cutting edge stuff I can today, it could change quickly. So just make sure you're staying up on everything, because I'm just giving you the stuff that is available to us right now. And that's what you see on the screen right there. A lot of what you're getting today is coming from the Society of Critical Care Medicine's guidelines on caring for the COVID patient that just came out 2 days ago, okay? Now, what I want to do first of all, before I get directly into ARDS and kind of the end stages of the COVID-19 virus, is just give you some of the information that I found in my research about the progression of COVID and how you get to ARDS. So I'm going to kind of take us through a couple of days or a couple of things about how we get to that end stage. So the information coming out of Wuhan shows that the incubation for COVID virus is 15 days or less. I'm going to guess most of you have heard that stat before. The average is that the symptoms start about 4 to 5 days after exposure to the virus. However, in my research, as you can see down there in the bottom, 2.5% of infected individuals started having symptoms in as little as 2 days post exposure. And by 11.5 days, basically 100% of people had started to develop the symptoms of coronavirus. So, you know, you can expect that by 10 or 12 days afterwards, if you're going to be symptomatic, you probably will be. The median incubation period, as we've been hearing on the news, is 5.1 days. Now, once you're exposed and you develop the symptoms of coronavirus, there's really three buckets that our patients end up in. The first bucket is mild symptoms. The patient has no pneumonia, or maybe a mild pneumonia, but overall they're fairly asymptomatic. They can manage their own disease at home. This is about 81% of our patients. Now, 14% of the patients will go on to develop severe disease. And severe disease is defined as having dyspnea, hypoxia, and more than 50% lung involvement within 24 hours. The remaining 5% of patients will develop critical disease. That's defined as respiratory failure, shock, and multi-organ dysfunction, which is really where I'm going to focus my talk today, is on that top bunch. Overall, the stuff coming out of Wuhan shows that progression tends to occur over 1 week. Now, when I say progression, we're talking about onset of symptoms to critical disease. So from the time the patient has their first symptoms until they end up critical has been about 1 week on average. Dyspnea tends to develop an average of 5 days after onset, and hospital admission, if it is going to occur, tends to occur about 7 days. And that shouldn't say after admission. Sorry, that's my typo. That should be 7 days after the patient has symptoms. Okay, so that's kind of gives you some idea. Now, where I want to focus today is on those last two boxes there that I've outlined in red. So we're going to look at patients with severe disease and critical disease and how to take care of them. And these are your patients that go into ARDS, acute respiratory distress syndrome. Now, before I get to ARDS, just to give you, again, information you probably are getting anyway, but I thought I'd present it here. What are the presenting symptoms that patients show up to their healthcare providers with? Well, in 99% of cases that are documented, fever is the presenting symptoms. However, 20% of those in those that have been recorded, they came in with a low-grade fever, and we say low-grade less than 100.4. So, you know, that's important to note. And I thought that other stat that you see there in Wuhan, the fever was only present in 44% of patients on admission. So only half of patients really had a fever at the time of admission, but then they went on to develop the fever after admission. So those are just some stats I found, but fever is kind of the big one you're looking for. And then other symptoms include fatigue, 70% of cases in those studied, dry cough, 59%, anorexia, 40%, myalgias, 35%, dyspnea, 31%, sputum production, 27%. And then as you can see, there's some uncommon symptoms, headache, sore throat, rhinorrhea, nausea, and diarrhea that have been recorded, but those are a very low percentage. So those are some of the symptoms that we're seeing our patients come in with. Now, when we move on now to severe and critical disease, what are some of the complications that you're going to see that are going to indicate that your patient is going on to into the serious form of this illness? And if we look at the statistics, most of these coming out of Wuhan, 17.7% of patients admitted went on to develop arrhythmias, acute cardiac injury, and shock, much like a septic shock syndrome. 33%, a full 1/3, develop cardiomyopathies. Now, I don't know what you're finding, but as I'm talking to my colleagues that are caring for patients, cardiomyopathy seems to be a bigger problem than even that 33% in that stat. So many people I'm talking about are seeing that, but certainly cardiomyopathies are part of it. But as we're going to focus on today, ARDS is one of the big syndromes that patients with severe disease go on to get. In one study I found, 20% of patients who developed ARDS would develop it within 8 days of their first symptom. Okay, so ARDS was 8 days post first symptom. In the second study, 41% of patients admitted with severe disease would develop ARDS. Okay, and as you've been hearing on the news and probably seeing in the literature, the majority of patients who develop ARDS are those over the age of 65, those with diabetes mellitus, and those with hypertension. So those tend to be your higher risk patients, and we've been hearing that. All right, so with that introduction, let's move on into what I wanted to talk to you about today, and that's acute respiratory distress syndrome. If there's one thing I would say today as I present this to you, it is that if there's anything that I think is encouraging as I spent the last 36 hours researching this to present to you today, Even though the COVID virus is creating significant numbers of illness, everything I studied showed that the stuff that we know and the stuff that we've been doing for, pneumonias, for ARDS, for all of this stuff, for other conditions not related to COVID, are the same as what we're doing for now, and they seem to be working. Now, we're seeing much greater numbers of these with the COVID virus, so we're getting inundated with it, but the stuff that the stuff that you've been taught seems to apply from what we can tell thus far. So I think that was encouraged to me. It's not that we're needing to do a lot of different things, it's that we're gonna have to continue to apply the things we knew. And the same would be said for acute respiratory distress syndrome, ARDS. This is not a new syndrome. We've known about this for years. It's been in the literature for decades, literally. We've seen it, and I've taught about it in my critical care medicine courses, in our, TCRN review courses. It's, associated with trauma. It's associated with pancreatitis. It's associated with acute lung injuries. So ARDS is not a new syndrome. We're seeing it with a significant number of severely ill COVID patients, but it's the same syndrome we've been talking about and you've probably learned about in the past. So if I give you a very high level overview of ARDS, this is a complex disease. And I'm going to do my usual teaching style where I try to take a very complex disease and make it simple. And some of you may think this is oversimplification, but let's just hit the easiest way to understand ARDS. So ARDS, as you can see in that top square on the left side, is an inflammatory response leading to microvascular and alveolar membrane integrity, or loss of microvascular and alveolar membrane integrity, okay? This is due to the inflammatory response. And I'm going to teach, if any of you who have sat through classes with me have probably seen the slide I'm about to show you, because I use it in nearly every class I teach, because understanding the inflammatory response really lays down the foundation for many diseases, not just ARDS, but understanding the inflammatory response will help you understand ARDS better. So I'm going to go way back to basics here and talk about the inflammatory response. Now, again, let me stress, I'm oversimplifying a very complex system, but let me see if I can make it really simple. The inflammatory response is driven by one of two factors. It's either driven by tissue damage or foreign substances like bacteria or fungi in the body. I've got a picture of a sliver, a patient with a sliver on the screen there. And I use that picture because the patient with the sliver probably has both of those things going on. There's tissue damage where the sliver went in, and the sliver probably introduced bacteria under the skin. So that patient has a twofold reason to have an inflammatory response. They have tissue damage and they have foreign substances introduced into the body. So what's going to happen is that tissue damage and those foreign substances are going to activate a very complex series of events known as the inflammatory response. And it's going to cause the activation of various inflammatory mediators. Now, you've been hearing a lot about these mediators if you've been listening about the COVID crisis and the cytokine storms and all that stuff. Well, cytokines are an example of a mediator associated with the inflammatory response. So when the inflammatory response is activated in the body, it leads to three main responses. The first one is going to be a vasodilation. Now, for good reason, right? If I have bacteria introduced under my skin, I want as many white blood cells at that bacteria as I can get there. So the vasodilation floods the area with white blood cells. Similarly, if I have tissue damage, I want as much healing nutrients like oxygen and glucose to flood the area. So that vasodilation floods the area with oxygen and glucose and other healing nutrients, right? So the inflammatory response, the release of these mediators and the activation of the mediators is going to cause a local vasodilation. It's also going to cause increased capillary permeability for good reason. I mean, you want those white blood cells out of the vasculature and into the area where the bacteria is. So the capillary permeability lets the white blood cells out. The capillary permeability lets the oxygen and the glucose out to initiate the healing process, right? So the vasodilation floods the area with these things, and then the capillary permeability lets them out. And then finally, your inflammatory response is going to change coagulation. Again, that's meant to control bleeding at the site of an injury, but it's also going to affect the coagulation cascade. That's why wounds get red and swollen. The redness is vasodilation. The swelling is increased capillary permeability, all going back to the inflammatory response related to tissue damage and foreign substances. Okay, now let's bring that back to ARDS. So you have a patient who has one of these two things going on. They have, of course, a foreign substance in the body, right? They got a virus, they got the coronavirus, and the coronavirus specifically affects the inflammatory response and leads to these cytokine storms and other things. And ultimately, especially if you have to put your patient on a ventilator, you're going to start to get some tissue damage there. That's on top of any damage that the coronavirus is specifically causing to the surface of the lungs. So you are getting that tissue damage. You are getting the foreign substances being introduced in the body, leading to this inflammatory response. And that inflammatory response in the lungs is going to cause the same things we just talked about. You're going to get capillary permeability, vasodilation, and potentially coagulation changes, right? Except it's in the lungs here because that's where the inflammatory response is greatest at this point. So the patient has this activation of the inflammatory response with an increased capillary permeability, vasodilation, and all that stuff. Now that capillary permeability is going to allow an exchange of fluid between the alveolar capillaries and the alveoli themselves. So now your patient is going to start to develop a non-cardiac pulmonary edema. As that capillary permeability allows the plasma to leak into the alveoli. So the patient's going to end up with this alveolar edema. Now, the next point there on the slide may not be true for COVID. Normally, we would say that patients in ARDS will have a pulmonary edema with a normal cardiac silhouette. And the reason that's important is because if you get somebody with a pulmonary edema, you want to differentiate, are they in pulmonary edema because of cardiac failure or because of ARDS. And if the cardiac silhouette is enlarged, that indicates heart failure, and the pulmonary edema is more likely to heart failure. Whereas if the cardiac silhouette is a normal size, then that probably indicates that it's not cardiac failure, and we call it ARDS. So normally that's one way we might differentiate pulmonary edema due to heart failure from pulmonary edema due to ARDS. Now, this may not always be true for the COVID virus, because as I said in the beginning, remember that, as 17% or whatever the percent was of patients who develop COVID also develop a cardiomyopathy, and that cardiomyopathy may cause an enlarged heart. So normally we would say ARDS patients tend to have pulmonary edema with a normal cardiac silhouette, and some of your COVID patients will fit that, but those that are developing a cardiomyopathy, they may have an enlarged cardiac silhouette. So that may be one difference you note, okay? So let's go back to this ARDS. The patient gets an inflammatory response, pulmonary edema resulting from that capillary permeability. They may or may not have an enlarged cardiac silhouette. As the alveoli fill with fluid, the patient becomes increasingly hypoxic because of this non-cardiac pulmonary edema. And they're going to develop a pulmonary hypertension. As the lungs become full of fluid, you're going to get that pulmonary hypertension. Blood's going to back up. You might start to see some right ventricular hypertrophy and enlargement, and you might start to see decreased left ventricular filling because of the pulmonary hypertension. That can drive some of that hypotension we see in these patients. Now, the effect of the inflammatory mediators within the lungs is also going to cause an inflammation of the alveoli, leading to alveolitis. And ultimately, the alveolitis is going to lead to fibrosis. And the normally elastic tissue of the lungs is going to lose its elasticity. And with time, the alveoli are going to become stiff and non-compliant. And that's going to create a lot of problems, as we're going to see when we get to the case study, in managing these patients. And then because of the fluid in the lungs and all that stuff going on, you have the perfect medium for bacterial growth. Your patient's going to develop secondary respiratory infections, get into the pneumonias, and they're going to end up with these stiff, non-compliant lungs. And when the ventilator goes to push air in, they don't stretch. So you get your high pressures on the ventilator. That can decrease the amount of oxygen that you can deliver to the patient. It can cause secondary barotrauma. And then when we try to stretch stiff, non-compliant lungs, we injure them more. The more we injure them, the more inflammatory mediators are released, the greater the inflammatory response. And we start to see this vicious cycle building of ARDS. Does that make sense? Kind of what ARDS is? Again, in the most simplified fashion that I can teach it, okay? Now, let's look at how ARDS would normally progress in just, let's say, a trauma patient or a pancreatitis patient. And this is actually pretty true for the COVID virus as well. So the screen you see, I actually use for my TCRN review class, but it fits mainly for COVID. And I'll talk about a few minor differences, but The beginning of ARDS is known as the impending insufficiency stage. And in this stage, the patient's physical assessment may be somewhat normal. Their blood gases may be fairly normal. Their chest x-ray may look normal. Overall, they look normal, but the patient becomes increasingly dyspneic. And any of you who have cared for those that are becoming seriously ill with the COVID virus, that's one of the earliest signs we see that the patient's going on into severe illness is that dyspnea, that early sign. And that's, that's part of ARDS. So you see that patient becoming dyspneic, yet their physical exam may not reflect the dyspnea that you're seeing. You may not see abnormalities on the x-ray at this point. Now, that dyspnea will cause them to breathe faster. So if you do blood gases in this early stage, you may actually find that the PaO2 is fairly normal and their PaCO2 is low because they're breathing fast and blowing it off. So your patient in the very early stages may come in with a respiratory alkalosis. Within 24 hours, the patient will go on to develop severe ARDS. It's a very rapid onset. And again, you talk to anybody who's cared for these patients, their rate of deterioration is very rapid. And that's classic with ARDS, that we've seen for a long time. So within 24 hours, the patient's oxygenation will quickly deteriorate. We'll see O2 sats drop. We'll see their PO2s drop. They'll become increasingly dyspneic if they're not intubated. They'll develop a hyperdynamic status with their cardiac index potentially elevating. Now you're going to start to see the patchy infiltrates on x-ray. Okay, you're going to start to see the pulmonary edema of ARDS. It's now going to become evident at this stage. Their physiological dead space will increase. And once they're intubated, you're going to find it takes higher and higher levels of PEEP in order to manage the patient. Okay, so that's how ARDS normally progresses, and that's very classic for what we're hearing for ARDS secondary to COVID. Now, there's two outcomes from ARDS. There's resolution, and looking outside of COVID, some patients do, survive ARDS. Sadly, many of them who survive, the fibrosis and the stiffening of the lungs that occurred during the ARDS continues in the resolution phase, and the patient may have lasting lung damage and loss of elasticity in the lungs and have some difficulty in the future. And it's too hard to tell, for any of your survivors of COVID, if that's the case, but it is likely that we may see that in your survivors of COVID. So that's those that resolve. But as we know from ARDS, most people actually go on into severe failure. So they develop this irreversible fibrosis, their lungs get stiff, and it gets harder and harder to manage them on a ventilator. They develop secondary atelectasis, they get the severe pneumonias, and then ultimately the amount of fluid in the lungs coupled with the fibrosis and the loss of integrity of the alveolar wall leads to profound untreatable hypoxemia. The patient loses their lung compliance. Now, normally in, say, a trauma patient, we would see them die within a couple weeks of the onset of ARDS. And the ARDS is often associated with a multi-organ dysfunction syndrome, where they may also go into renal failure and go into heart failure and so on. Now, we do see some MODS, multi-organ dysfunction syndrome, with your COVID patients, but we do see death occurring much quicker with COVID than you would with a traditional ARDS. Okay, so that's kind of the process of ARDS normally. Now, ARDS is marked by 4 classic findings. Now, with COVID, really only 3 of these 4 work, but let's talk about all 4. The first is its acute onset, and we've already talked about that. ARDS tends to have a very rapid onset with dyspnea, starting, and then within 24 hours, the patient requiring intubation. And that's very common in ARDS, and we're seeing that in our COVID patients. We also see the bilateral infiltrates on x-ray. Now, those may not be there initially. Remember that beginning, we don't always see the infiltrates right away. They can take up to 24 hours to develop, but once they're full into it, you're gonna see the patchy infiltrates like you see on the x-ray there on the screen. Now, the third point may or may not be appropriate with COVID. Normally, as I've already talked about, there's no evidence of cardiac cause. In other words, the cardiac silhouette is a normal size. With COVID, it may be enlarged, and there may be some cardiac involvement as well, and that's because of the cardiomyopathy. So that one may not fit exactly. The fourth kind of classic finding of ARDS is an altered PF ratio, PaO2 FiO2 ratio. I'm going to spend some time talking about the PF ratio. For those of you who work critical care, you may be very familiar with this. It's used all the time. But for those of us that don't work critical care regularly, we may not be as familiar with the PF ratio. So let me spend some time on it. So the way I define the PF ratio, you can see it in italics there on the screen, an indirect measurement of the degree of oxygenation across the alveolar membrane. So when I'm talking about a PF ratio, what it is an indirect measurement of how much oxygen is going from the alveoli across the alveolar surface and into the blood. Okay, so it's just really a measurement of how much gas is getting across the alveolar membrane. And it's pretty easy to do this. All you want to do is look at how much oxygen you're delivering. So how much is in the alveoli? And how do we know what's in the alveoli? Well, the patient's FiO2. What percentage of oxygen do you have them on? Are they on room air? Well, it's 21%. Are they intubated on an FiO2 of 100? Then it's 100%. So the amount of oxygen in the alveoli is the FiO2. And then how do we know how much oxygen gets into the blood? The PaO2, right? Which you're going to get in your blood gases. The PaO2 is how much gets into the blood. So what I expect to see is that if I'm giving a patient 60% oxygen, I expect to see that 60% oxygen in the blood if the alveolar surface is working. It's going to cross. But if the alveolar surface is no longer working, if it's full of fluid, or if it's no longer conducting gases, then I'm going to find a much higher FiO2 inside the alveoli and a much lower PaO2 because it's not crossing the membrane. So this ratio is just telling you how much is getting across the membrane. It's comparing what's in the alveoli to what's in the blood. Now, as you can see on the bottom of the screen there, when you do a PF ratio, and I'm going to tell you how to do it in a minute, any value above 400 is considered normal. And that's what your goal when you're caring for these patients is to keep their PF ratios above 400. A worrisome PF ratio is 2 to 400, and a severe PF ratio or severe disease is any PF ratio less than 200. Now let's actually apply this. Let's do this in some patients to make this make sense, okay? So that first lady there on the left side of your screen, we're gonna consider her healthy. She's got no lung problem. She's not an ARDS. You do her blood gases, her PO2 is 100, right? Now, if you see 100 on a healthy patient, what are you gonna say? Good job, great, you got a great blood gas. You're diffusing all your oxygen across the alveolar membrane. Love to see a PO2 of 100 on anybody. Now, she's breathing room air. We know that the percentage of oxygen in room air is 21%. So to figure out the PF ratio, I take the amount of oxygen in her blood, which is 100 millimeters of mercury, and I divide that by the FiO2, the percentage of oxygen she's breathing, which in this case is 21%. When I divide those, I get 476. So her PF ratio is 476. Now, what did I tell you? Anything above 400 is normal, right? So she's great. She's got no problems. Her PF ratio is perfect. She's above 400, which is meaning that any oxygen going into her lungs is crossing the alveoli and getting in the blood. And that's what we want. Okay, so she's got a great PF ratio. Now look at our intubated guy on the screen there on the left. Now his PO2 is also 100. So you might say to yourself, wow, we're doing a good job on this guy. He's got a great PF ratio, or he's got a great PO2, right? But he's on 80% FiO2 on that ventilator, right? So he's getting 4 times more oxygen than the woman is because he's 80 and she was, well, 21. So it's almost 4 times as much. For easy math, we'll say 4 times as much. She was getting 21%, he's getting 80, so he's getting 4 times as much. So if you're pushing 4 times more oxygen in his lungs, how much more oxygen should be in his blood? Well, if his alveoli is working, there should be 4 times more oxygen in his blood. So what should his PaO2 be if he were perfectly healthy? You should have a PaO2 of 400, right? Because he should have about 4 times as much oxygen in the blood if he's getting 4 times more oxygen in the lungs. But his PO2 is only 100, which tells you what? That only 25% of the oxygen you're delivering is actually getting into the blood. 75% of the oxygen you're delivering is not getting to the blood. It's blocked somewhere. Is it blocked in, a tight bronchi? Is it blocked because of fibrotic alveolar walls? Is it blocked because of pulmonary edema? Who knows? But we know that he is only getting 25% of the oxygen you're delivering. That's problematic. Now, how do we figure that out? By doing a PF ratio. We take his PO2, 100, divide it by his FiO2 of 80%, and you get 125. Remember what I said 125 was? severe. This guy's in severe disease because his PF ratio is less than 200. So be careful when you're looking at somebody's blood gases. Don't just look at the PaO2. If you want to truly know the degree of disease, you need to compare the FiO2 to the PaO2 because that's going to tell you the degree of disease. Does that make sense? Hope so. So let me just give you, kind of the high level of PF ratios. Any PF ratio above 400, we already said was healthy. A PF ratio calculated at 2 to 300 is considered mild ARDS. That would be the equivalent of somebody being on a PO2 of about 60 on room air. So, if the patient's PF ratio is coming back at 2 to 300, if you took them off the ventilator and put them on room air, they would probably get a PO2 of 60. Moderate ARDS is 1 to 200, that's a PO2 of 50, and severe ARDS is less than 100, that's a PO2. That would be the equivalent of a PO2 of 40 on room air, okay? All right, so that's a brief overview of ARDS. Now, what I want to do is look at what the Society of Critical Care Medicine released earlier this week as their recommendations on how to manage these patients with COVID crisis. Now, again, this is information as of today when I'm taping this, but you'll want to keep on top of things because they change quickly. What they're recommending is that you only use oxygen if the patient's satting below 90%. Okay, if the patient's satting above 90%, they're not recommending oxygen. Now, they said between 90 and 92, you may consider it depending on patient age and so on, but certainly we don't need to be giving oxygen to everybody. And certainly if their SATs are above 96, do not use oxygen. We've known this for a long time, but the liberal use of oxygen can create all kinds of new problems. Okay, so if the patient is satting above 96 when they come in, do not give them oxygen. If they're satting less than 90 to 92, then consider giving them oxygen, but your goal is to get the oxygen between the O2 sats between 92 and 96. So you're going to titrate your oxygen to a sat of 92 to 96, okay? Now, if you can't get the oxygen up to 92 to 96 with just general nasal prongs or face mask, then the recommendation is that you go to high flow nasal cannula oxygen. Now that's only going to be reserved for those who you can't get up there into the 92 to 96 range with just standard oxygen therapy. Now I realize not every hospital has high flow, so if you don't, you can consider non-invasive positive pressure ventilation, your CPAP BiPAP. However, they're not really recommending CPAP BiPAP. Number one, it hasn't been shown to work very well in the COVID population. And number two, it aerosolizes the disease and puts others at risk. So there's not a lot of evidence to go to NIPPV, non-invasive positive pressure ventilation, unless you need that to temporarily tie over until intubation. High flow is preferred. And if you can't manage the patient on high flow, it's best to go right into intubation. There is the option to do non-invasive if necessary as a tie over, but it's not really a recommendation currently. Okay, so that's kind of the current recommendations. Now, once you get to the point where you have to intubate the patient, here's their current recommendations for ventilator management. And let me just say that if you didn't watch it, I did a module on Monday that's available on Facebook and YouTube on basic ventilator management. And having watched that video will certainly help you in what I'm going to teach you now. So if you haven't watched it, you might want to watch that as part of this. But what the current recommendations are from the Society of Critical Care Medicine is that your patients with COVID ARDS be started on a low tidal volume. Now, their recommendation is somewhere between 4 to 8 mils per kilo of predicted body weight, okay? And I'm not going to go much deeper than that. If that doesn't make sense to you, watch my module on Monday, okay? Because that's a whole nother thing we're going to cover there. But if you watch it, that'll make more sense to you. So you're going to use a 4 to 8 mil per kilo of predicted body weight. And they recommend that you start at 6 mLs per kilo and then titrate up or down as necessary based on the CO2. The other big thing, and this is no different than any other ARDS patient, and that is to use higher PEEPs. I mean, PEEPs work very, very well on ARDS for any case, and they work for COVID. It's been shown to work. So PEEPs above 10 centimeters of water, just remember that the lungs of the ARDS patient will become more fibrosed, and those higher PEEPs can cause barotrauma. So you'll need to watch your plateau pressures. You'll need to monitor your patient for a barotrauma, and in a worst case scenario, a pneumo. You want to keep your plateau pressures less than 30 centimeters of water. The other thing, and I'm going to do a case study with you here on the next screen, but The other thing to remember is if your patient has blood pressure issues, don't use crystalloid resuscitation. Crystalloids are not recommended, or minimal crystalloids are recommended if necessary for fluid resuscitation, but crystalloids are going to end up in the lungs and they're going to contribute to ARDS. So you want to use a conservative fluid strategy, and minimize the amount of fluid you give these patients, because if they go into ARDS, that fluid's just going to contribute to the mess. So it's better to use a vasopressor for blood pressure management as opposed to a fluid bolus. We also want to, as with any patient, reduce ventilator times as much as possible. Okay, so those are your current recommendations from the Society for Critical Care Medicine. So let me do a case study with you. Now, as I go into this case study, a couple of things I want to tee this up with. First of all, I want to thank several of my coworkers, some of my flight nurse coworkers who helped me develop this. We kind of bounce it off each other. So, you know, it's a couple of minds that put this one together. We also used an actual case study that we found of somebody who survived COVID. So some of this, not all of it, but some of it's kind of based on a real life case study. But let's walk through what somebody might go through who goes into ARDS secondary to COVID. Okay, so day one, the patient, the first day of symptoms, they have a dry cough, there's no fever, they feel like they have bronchitis. By day 3, the bronchitis symptoms have worsened and now they have a fever. Day 5, the temperature is 102 Fahrenheit. They go to see their physician and their physician diagnoses them with pneumonia and they're started on antibiotics. Day 7, the fever and symptoms persist despite 48 hours of antibiotics. So they go to the ER. In the ER, their SATs are measured at 88%. So they're admitted to the inpatient unit and they're put on 1 liter of oxygen, and that 1 liter got them above the 92. So they're maintained at 1 liter. But by the next morning, day 8, their SATs are dropping and 2 liters is required to get their SATs above 92. On day 9, it requires 3 liters, then 4 liters, then 5 liters to maintain their oxygen SATs at 92%. So we see more and more oxygen required. And by day 10, they're moved to ICU and they're put on a high flow nasal cannula, and that's required to keep their SATs above 92. Partway through day 10, they require intubation. Okay, so now we're going to move on into the intubation. So the night of day 10, the patient goes into severe respiratory distress, develops dyspnea, and requires intubation. Here's the blood gases you get that night when you intubate the patient. So pH is 7.19, PO2 of 74, PCO2 of 50, and a bicarb of 20. Now, I'm not going to do any blood gas interpretation for you. As you might remember, we've released our ABG module for free that you can watch. So if you need to review that, do that separately. But I'm just going to give you the interpretation here. So this patient is in a acidosis, right? pH less than 7.35. Their CO2 is high, so they got some sort of a respiratory involvement. Their bicarb is low, so there's some compensation. So they're a compensated respiratory acidosis. But the other thing that stands out to me there is that PO2. It's a little low. It's not crazy low, but it's too low. So 74 millimeters of mercury. So that's what we're going into this intubation with. Now, their blood pressure at the time of intubation is 92 on 64. So I'm going to ask you, but I'm going to answer the questions because I honestly can't see the responses you're putting on Facebook right now. So you can certainly throw your responses out there, but I'm going to give them to you. What would you set your FiO2 at? Just looking at those blood gases and that history I've given you, where would you start your FiO2? Hopefully you said 100%. Probably just because we just intubated the patient and they were on a high flow before we intubated them. We're probably going to need to maintain that. So I'm going to say we're going to put them at 100%. What respiratory rate do you want to start them at? Remember, respiratory rate's going to affect mainly CO2, and this CO2 is a little bit high, right? So if I want to blow off a little extra CO2, let's turn that respiratory rate up. Normal respiratory rates are about 12. So why don't we set it at 16? 16, a little higher than normal. That'll allow the patient to blow off some of that CO2 they're accumulating. So we're going to go with the respiratory rate of 16. Tidal volume. The guy weighs 70 kilograms. So what do you want to set your tidal volume at? Remember, tidal volume also affects CO2. His CO2 is high. However, remember what the recommendations are for tidal volume? Using a low tidal volume. So because we've turned the respiratory rate up and the respiratory rate will help get rid of CO2, why don't we start with a lower tidal volume? Because we know that higher tidal volumes in ARDS can cause damage because the lungs get stiff. So let's see if we can manage him on a lower tidal volume. So I'm going to start on the recommendation of the SCCM and start him at a 6 mLs per kill tidal volume. So if he weighs 70 kilograms, 6 times 70, round it up. is 400. So I'm going to start him on a 400 ml tidal volume. Now, something I didn't talk about in my video, but I'll talk about it here, is what his minute volume is. And his minute volume is looking at the number of breaths per minute, 16, and multiplying that by the tidal volume, 400. 16 times 400 is 6,400. So you're giving him 6,400 mLs of oxygen or of air per breath, and that's the minute volume. Now you want your minute volumes between 6,000 and 8,000 for best outcomes. So his minute volume is coming out at 6,400, so that's fine. I mean, we'll look at that a little bit more later, but for now, that's good, okay? And then finally, what are you gonna set his PEEP at? Okay, what are you gonna set this guy's PEEP at? His FiO2 is at 100, respiratory rate of 16, tidal volume of 400, his minute volume 6,400. What do you want to PEEP him at? Now remember, PEEP's going to directly affect oxygen, but PEEP has a negative effect on blood pressure, and his blood pressure ain't great. I mean, it's not the worst we've ever seen, but it's not the best. So if I start putting him on a high PEEP, I'm going to drive down that blood pressure. So I know he needs oxygen, and PEEP's going to give him oxygen, and SCCM is recommending a high PEEP, but I want to be careful with that PEEP when I first put him on, or I could tank out his blood pressure, and that's going to do him no good. So I'm going to start his PEEP just a little bit above normal. Normal would be 5 centimeters of water. I'm going to try him at 7. I mean, his blood pressure is not great, but it could be worse. So let's just try him at a little bit above normal. Hopefully that drives up his oxygen a little bit without driving that blood pressure down. So what do you think of those vent settings? Would you agree with me on those? That's what my colleagues and I decided we were going to do on this patient. Okay. Now, let's go 1 hour later. So you put him on the ventilator, you put those settings on. 1 hour later, you redraw his blood gases. So his pH is now up to 7.24. So that's heading up towards normal. So, hey, that's a good thing. His PO2, hey, look at that. That's heading in the right direction. That's not a bad PO2. Not the best. It's not the best PF ratio, but it's not the worst PO2. His PCO2 is dropping down to normal, 50 down to 44. So we're starting to normalize that. That respiratory rate's working. And his bicarb is 20. And that's going to take a while to fix. So whatever. But look at what the PEEP did to his blood pressure. Put it down to 88 on 50. I don't like that. That's a map of, I've got to do the math in my head. A map of what, 60, 62? Yep, that's too low of a map. So his PEEP has driven his blood pressure down. Now, again, we have him on the vent settings of an FiO2 of 100, respiratory rate of 16, tidal volume of 400, a PEEP of 7. So based on what I just gave you, what do you want to do for him now? How do you want to manage this guy? You want to change his vent settings? What do you want to do with him? What's your highest priority 1 hour after intubation? Well, I'm going to give you what I think we should do. Let's manage that blood pressure. There's not much we can do until we get the blood pressure up and get that map up. I don't like that map that low, and I certainly can't do much with the vent with the map that low. So we're going to manage the blood pressure. Now, just to let you know, the recommendations for managing the blood pressure are not fluids. We already said that. Fluid bolus is probably not the best choice here. So instead, they're recommending norepinephrine as your first line, titrating. And if you don't have norepinephrine available, considering epinephrine or vasopressin. So those are the current recommendations from SCCM. So we're going to put our guy in a norepi drip. We're going to titrate it and try and get that blood pressure up, okay? So he's on norepi. It is now 2 hours post-intubation. We redo his blood gases. pH is 7.28. Starting to drop again. PO2, starting on the downward trend. It's 80. PCO2, well, it's in normal ranges, 42. And the bicarb's heading back to normal. So at least we're fixing the compensation side of it, right? Fixing the CO2 side, but we're not fixing the O2 side. But we got his blood pressure back up. Excuse me, 102 on 78. So, hey, the norepinephrine worked for that, right? Gave him a decent map. Now, here's his vent settings: FiO2 of 100, respiratory rate of 16, tidal volume of 400, PEEP of 7, a minute volume of 6,400. So now what? What do you want to do with this guy now? Give me a minute to think about it, but I'm hoping that you're saying we still got to work with that oxygen level. That PO2 needs to go up, right? We need to get that up. The other thing that concerns me is that FiO2 of 100. That's fine temporarily, but we got to get that down, right? So the only way to get the FiO2 down with a PO2 of 80 is to increase the PEEP, right? Because FiO2 and PEEP are what elevates O2, and we need to get that O2 up, and we want to get the FiO2 preferably down below 60. So how can we get the PO2 up? Well, give him a little bit more PEEP, right? But if I give him more PEEP, he has to have a good blood pressure. Well, he's got a fairly decent blood pressure. So I tell you what I'm going to do. This is what we decided, my colleagues and I. We were going to change his FiO2 down to 70%. That's where we were going to go. Okay, so we're going to go down to 70 on the FiO2. Now we're going to leave the respiratory rate and tidal volume alone right now. They're giving you a minute volume of 6,400. His CO2 is pretty normal. Let's just leave those alone. But let's turn that PEEP up, because if I turn his FiO2 down, we're going to tank out his PO2, right? So I got to make up for the lower FiO2, and I'm going to do that by raising the PEEP. So I'm going to raise the PEEP up to 10 centimeters of water. Okay, so now the patient's on an FiO2 of 70, a PEEP of 10, and then his respiratory rate 16 and his tidal volume is 400. Now what? Now what do you want to do? Well, let's sit on him for a while and see what those ventilator settings did. So now we're 3 hours post-intubation. Blood gases, 7.30, yay. Okay, so we're doing a little bit better on the pH side of things. PO2, did much better on that, right? Got that up to 84, still not great, but better. PCO2 is 38, still dropping, and his bicarb's 22. Now, with the elevation in the PEEP, his blood pressure has gone back down to 94 on 70. So remember, that's on the vent settings of an FiO2 of 70, respiratory rate of 16, tidal volume of 400, and a PEEP of 10. So now what? Well, hopefully you said we got to remanage that blood pressure. We probably want to get that PEEP even higher and that FiO2 lower, but I can't do that with a 94 on 70. I could try, but I don't think I want to. I don't want to play too much with that PEEP. So again, we're going to have to manage that norepinephrine drop, try to get that pressure up a little bit more so we can keep elevating the PEEP, okay? Now, let's just go to the next morning, because I think you're getting the idea of what I'm doing here. I'm hoping you're following my train of thought, but it's now day 11, the next day, and the x-ray shows a complete whiteout. So our guy is deteriorating into full-blown ARDS. His pH has dropped to 7.08, his PO2 is 60, his PCO2 is 56, his bicarb is 16. So we're seeing him deteriorating rapidly despite intubation, despite treatment. His blood pressure is 76 on 50. Now what? What are you going to do with this guy? Well, of course, we have to manage his blood pressure because his MAP is way, way too low. But we also have to recognize that that PO2 is also now dropping into kind of crazy low levels. So we're going to have to fix it. Now, what can you do to fix that PO2? Well, you can't elevate the PEEP, right? Because his pressure is too low. So the only option you have is the FiO2. Now, I don't like to see FiO2s above 60 for a prolonged period, but what are we going to do here, right? So for the sake of this argument, we're going to increase his FiO2 to 90%. And then his PCO2 is also climbing. So we're going to turn his respiratory rate up to 20 to see if we can't get rid of some of that CO2. And then what I'm going to do in turn is, because he's obviously going into ARDS, I want to get that tidal volume down to reduce barotrauma. So we're going to reduce his tidal volume down to 4 mLs per kill. That's going to take him down to a minute volume of 6,000. Now you might say, why? Why are you doing that? His CO2 is so high. You're right, it is. But I'm going to guess at this point, in the degree of ARDS he is in, he's probably having some alarming high pressure alarms on the ventilator, and that's going to affect his oxygenation. So we're probably going to have to start allowing for some permissive hypercarbia. We're going to have to trade off a lower tidal volume for a higher CO2 and accept that, because as the lungs get stiffer and stiffer, you can't push that tidal volume in. And really the highest we can go on a respiratory rate is like 20 to 24. So we're already starting to max that out. So let's try to turn that respiratory rate up, turn the tidal volume down. I'm not sure it's going to fix the CO2 at this point, but, and then the PEEP, well, let's leave it at 10. Let's see if we can manage the blood pressure with some norepinephrine and get it back up. If we can't, I don't know, but I certainly don't want to turn the PEEP down now, because I've got some recruitment going on. And as you can see, we might be losing the battle on this guy. I think that's the end story. I'm not going to take the case study any farther than this, but I hope you followed where I went with this case study. All right. Just a couple other things we're going to be closing up, because I've probably gone over time already a little bit, quite a bit actually. So prone positioning is also being recommended by SCCM. If you're not familiar with prone positioning, it's exactly what it says. It's caring for the patient on their stomach. There's a couple reasons why prone positioning works with ARDS. First of all, when a patient's lying on their back, their heart is going to put pressure on the lung, right? Because the heart's above the lung. So that means the left lung is going to have less volume. When I flip the patient over on their stomach, the heart goes to the chest wall and it expands the amount of oxygen I can get into the left lung. So you get some extra out of that, but it also has to do with gravity. When you're laying on your back, gravity is going to cause the blood flow in the alveoli to be in the back surfaces of the lungs, right? And if there's a lot of fluid, gravity's also going to pull the fluid down to the back part of the lungs where all the blood flow is. So all the blood is in the part of the lungs that's got fluid in it, and it's not getting oxygen. And then with time, that fluid is going to fibrose the back of the lungs. So the most fibrotic areas of the lungs are also the areas of the lungs getting the most capillary blood flow. So if I flip the patient over on their stomach, that's going to cause the capillary blood flow to move to the front where there's less fibrosis. And then I can get better oxygenation through those less fibrosed front alveoli, okay? So that's why we prone people, put them onto their stomach. The current recommendation from SCCM is to consider prone positioning for 12 to 16 hours, especially if it improves the patient's oxygenation. The last thing I'm going to just say is the other thing that can be considered, I'm not going to go into this because of time, but that would be ECMO. If your hospital does ECMO, or if you're able to transport the patient to a hospital that does ECMO, that may be an option. And that's all I'm going to say about that. Now, to bring this to a close, yes, we are at the end. This is a great flow chart that comes from the SCCM stuff. You can see at the very, very bottom how you can look it up on the internet if you already don't have access to it. I would love to go through this with you, but I don't have time, so I'll let you look that up. And then there's another great flow chart that goes over everything I just gave you. So I just put these flow charts into action for you, okay? Now, here's the resources, the references I used. The last resource on there, the Society of Critical Care Medicine, is where I got those charts from. So you can pull those up and look at those, and those will make what I said come to life. Finally, I just want to remind you of the resources that we're trying to make available to help you do your job. Our ABG lecture has been made free. It's available, and you can see on the screen the address where you can do our 45-minute ABG interpretation lecture. This past Monday, I did a ventilator lecture. It's available on both Facebook and YouTube. You can access it. You can see there where to find it. Next week, we're going to do 3 webinars for you like this one for free. On Monday, March 30th at 7:30, Kara Bauman is going to be presenting a topic she's been doing where she's training non-ER nurses to work in the ER in preparation for an increased volume. So she's going to talk about what things she's teaching non-ER nurses, what they need to know to work in the ER. Any of you who are educators or managers, this would be a great session for you, but even staff nurses, I think Kara's got some great things to teach you about when you have to work with someone who's got pulled to the ER, how can you help them think differently? So she's going to do that on Monday at 7:30 Eastern. Wednesday, April 1st at 7:30 Eastern, we're going to do what you asked for. Everybody asked us to do a sedation on the ventilated patient. So Kristen Klein will be doing a session on sedation and the ventilated patient, how to sedate them, especially with COVID. You won't want to miss it. Friday at 7:30. Andrea Perry, one of our instructors, she's already working out in a tent. They've set up a tent and she's been working it. And she wants to talk about all the lessons she's learned about setting up a tent and how to work in there. So, you know, if you think that that might be something you're going to be doing in the future, you won't want to miss Andrea's lecture. We're going to make those town hall styles so you'll have more interaction than you did with me today. Also next week, we are going to be taking our regular courses online because we know you need CEs and some of you are still studying for your certifications. So Monday, we're going to be doing medical emergencies from the CEN course. Tuesday, we're going to be doing hematological studies from our analysis paralysis lab course. Wednesday, we're going to be doing the MODS lecture from our TCR and review course. And Thursday, we're going to be doing triage and development from our CPIN course. The information on how to sign up for those is on our Facebook page. If you're wanting to do a review course with us, now's the time to do it online, especially if you're stuck in quarantine or whatever. I want to thank the people behind me. You see me on the camera. Michael Fredericks, who is our director of marketing, does all of the technical aspects of these webinars, and I want to thank him for his tireless work. Bill Light, our chief clinical officer, has been doing all the research that goes into these, and he also helps answer the questions on Facebook. And Olivia Simpson, who is our director of operations, is helping to answer questions on Facebook. I couldn't do it without this amazing team that helps me with these webinars. And I couldn't do it without you guys supporting us as well. Again, let me say what I said last time. Thank you for what you're doing. I want to give you applause. And keep up the good work and let us know in the comments if there's other topics you would like us to cover. Thanks and good night, everybody.